Good morning. You're listening to Retake Our Democracy, a 30-minute weekly show that airs at 8:30 a.m. each Saturday morning on KSFR 101.1 FM, your Santa Fe public radio station. I'm Paul Gibson, the host of Retake Our Democracy, and today I'm going to be speaking with Mary Feldblum, the Director of Health Security for New Mexicans campaign, and we'll be discussing the status of the health security plan and design process and what's coming up in 2022 in the session. Last week, Roxanne and I did our first show since my stroke on July 21st. It felt great to be back at the mic. We'll get to our discussion with Mary in just a moment, but there's a few announcements I'd like to make. I want to first acknowledge that we are conducting this interview on stolen Tewa land and to thank our Tewa neighbors for being such good stewards of the land. I also want to remind you that the 2022 legislative session is just a bit over 3 months away, and Retake will be operating our legislative alert system again this year, just as in the past. If you sign up for our alerts, anytime one of our transformational bills is scheduled for a hearing, we send you an alert that includes a summary of the bill, speaking points, and contact info for your legislator. This year, in part due to the stroke limiting my capacity, we are going to limit the number of bills we support to far fewer than the 45 we supported last year. We don't want to spread ourselves too thin and let you down. And another reason for having less bills is that this is going to be a short session, so there won't be as many bills introduced of substance. It's going to all have to be on the governor's call. You can sign up for alerts by going to retakeourdemocracy.org, and at the homepage on the right side, you'll see a red sign up button where you can just click there and sign up. If you're interested in learning even more about how the legislature works and how you can raise your voice more effectively, you should participate in our semi-weekly, twice a month legislative huddles that will begin in the first week of November. Zoom strategy huddles are held on Friday from 3:30 to 4:30, and we generally examine what happened the week before and take a look forward. But we also talking about what has transpired, you begin to understand a little bit more about how the process works and doesn't work. So we really encourage people to be part of that huddle process. It also creates a retake community, and that's kind of nice to connect with people. Finally, if you're driving around today and you don't catch all of today's show, you can watch it and all of our past shows by going to retakeourdemocracy.org and hovering over the actions and events page and clicking on Retake Conversations. So that's the announcements. Let's get started. Welcome, Mary.
Welcome to you. I'm so glad to see you so healthy.
Yeah, well, it's good to be back, and I'm way excited about this because it's much easier to do an interview than to do a solo show or a show with Roxanne where we carry the full weight of the conversation. So let's start with the first simple question. I always like to let our guests introduce themselves, and you've been in this for a long time, but can you tell us just a bit about yourself and how you found your way into advocacy for near universal health care coverage in New Mexico? And before you do, I want to interject that I'm guessing you're one of those advocates who might carry around a sign saying, "I can't believe I'm still carrying this sign," as you've been fighting for health security in New Mexico for decades. Fill us in on how you became involved in this effort, Mary.
Well, my PhD is in sociology and economics, and I have a heavy economics background. And I was an academic, and when I moved out to New Mexico in 1986, I got involved in policy, particularly environmental policy in the early 90s. Consumers Union, the publisher of Consumer Reports, hired me to direct their New Mexico healthcare project, which is how I got involved in this. And I can believe that this is taking a long time. Think about civil rights, think about women's suffrage, think about child labor. What we're trying to do is change the system that is so dependent on private insurance and a very complex administrative structure that is actually over the top. And what's exciting for me is to see how more and more people are interested in the health security plan and how it functions, how it would work, and there, it's changed over the years because of input from all kinds of people around the state. We're the largest coalition in the history of our state.
Well, that's impressive, and you're to be commended, because I know how much work it takes to run something like this, and you've been doing a great job. To refresh our listeners' minds, can you start by telling us what happened in 2021 session and what comes next in 2022 and beyond?
Well, to kind of refresh your listeners, um, the health security plan, which I'm sure most of them know, would enable New Mexico to create its own health insurance plan, like a co-op, that automatically covers as many New Mexicans as possible with freedom of choice of doctor, good services, and our premiums go into this plan, not into the pockets of the insurance industry. So the question then becomes, because there are lots of states that have had bills like Health Security Act and California, all of them, but we're the first state to actually roll up our sleeves to say, okay, how do you really do this? There are a lot of important decisions that have to be made. It's very complex in setting up what I call a social justice insurance plan. And in the past session, the legislature authorized $575,000 to begin what is called the design process, which will take probably 3 to 4 years. We need to do this right, carefully, with lots of input from healthcare professionals as well as the general public. And that is really critical for this plan to be created and set up. So the bill itself won't be introduced until 3 or 4 years down the pike.
Okay, so what you got was authorization and some funding to do a design plan.
Mhm.
And so basically what that's going to do is be able to come back to the legislature and say, this is exactly how it's going to go, not a concept. And this is exactly how it'll be paid for and what it'll save the state, et cetera, et cetera.
Right. What's important is that there have been 3 studies in New Mexico that have done a cost analysis of the health security plan. And all 3 showed that if you self-insure most or all New Mexicans into one old-fashioned health risk pool, you're going to see dramatic savings. Not that health costs go down, but the comparison between this plan's rising costs and the current system, which is out of sight, is what they're talking about in terms of savings. But they're all doing projections. None of them knew exactly how physicians would be paid, much less how hospital budgets how much hospitals would be paid, how the specific enrollment would occur. I mean, there are a lot of details that need to be worked out in this plan. And all of us need to be involved in understanding what we don't like about the current system and ideas about changing it. It's a great opportunity for healthcare professionals, for all of us to have a system designed that is going to finally be health professional and patient friendly.
Okay, so I'm joining you by video now. I changed the view. That won't make much difference to our radio audience. So you got some funding for doing this plan and design process. How is that process going, and what do you expect to be the end result of the process?
Well, the 575,000 went to the superintendent of insurance. He's overseeing this process, and Representative Armstrong and Senator Ortiz Pino are our 2 major sponsors. And several of us met with him because the superintendent of insurance said, this is a big plan. There's a lot of decisions. And he wanted to first focus on the research that could be accomplished during the first year. The 575 is for a fiscal year. So it began July 1st of this year and will end June 30th of next year. So of course, we're going to need future funding, and I'll go into that later. So he wanted to figure out the research and what should he focus on. And so we made suggestions, which he completely accepted. And so no decisions will be made. That's, I think that's important for people to know. the question is, is to learn about the lay of the land. What are the, what information do we need in order to make these complicated decisions? And this is the first step. The first step is, number one, is figuring out, because we don't want to lose any federal dollars, right? We don't want to lose any Medicaid dollars. What waivers, what agreements can we reach to make sure that Medicaid can be rolled in? Can Medicare, is a question. How would it work for veterans? And the tribes as sovereign nations can voluntarily join, and certainly they don't want to see 1 penny of IHS dollars lost. So there's, what are the agreements that we need to seek, and what waivers can be achieved. And and the superintendent has found what he calls a waiver guru from Washington, and it's a team of people who know where all the bodies are buried. They know where what's what. So that's very important. The second research topic is, this is going to take 3 to 4 years for all of us to figure out how this plan will actually work, so that when we're enrolled, right, we can go to the doctor of our choice and they're paid in a timely fashion. It's such a tremendous amount of work that has to go in there. And so one question, of course, is problem with the studies that have occurred in the past is they were all projections. And so what will have to be done is a cost analysis of the plan as designed, not as projected.
Right.
And that's, so that'll be 3 or 4 years down the pike. So the superintendent asked Dr. Jim Peach, who's a well-known, he's a professor emeritus at New Mexico State, if he would look at the Health Security Act and the plan, and he's familiar with methodologies to do cost analysis like this. So what needs to be gathered? What information does an economist need 3 or 4 years down the pike to be able to project the cost of the plan? And so his job was to do a blueprint. Now, there are other decisions that will have to be made that wouldn't go into that. No economist doing a cost projection is going to include how exactly an appeals process is going to work, for example. So he's looking at the major data that's needed to perform a cost analysis. And I need to, the word cost, by the way, is used very loosely. You hear, what is it going to cost me? What is it going to cost the state? So let's be clear what we mean by cost. By cost of the plan as designed, that's step number 1, because you can't figure out what it's going to cost you and me, or the impact on the state, until you have that number. And then once you have that number, then through the waivers, all that research, will be able to figure out what public dollars can be used to offset the cost. And then that remainder will be made up with premiums and employer contributions.
So let me ask this, Mary. Then I'm taking it that part of the plan and design session will be to actually figure out what the cost for every kind of service might be, and what services, what medical care would be eligible for a reimbursement.
Yes, ultimately that has to happen,
And
because in order to do a cost, you need to know exactly what you're paying healthcare professionals. You're gonna, and so that gets me into, so Dr. Peach has been working on the blueprint of what's needed to come up with a real cost analysis of plan and design. Then the third topic is what you're getting into, and that is how providers will be paid. Before you figure out the amounts, you have to figure out the method. Are they going to be, is it going to be fee for service? Is it going to be capitation? The United States has systems developed because we're very critical of fee for service in the United States. So there are all these systems that essentially put the risk onto the healthcare professional. In other words, if a capitated rate, you get a certain amount per month for your patient, right? If you go over budget, you eat it as a provider. And that's called a risk-based method. So instead of the insurance company or Medicaid taking the risk, the provider is taking the risk. So also, what's happened in the United States is patients take the risk, because we see that more and more higher deductibles, higher co-insurances. So the shift is on those of us, the consumer and the provider, as big solutions. And in Europe and Japan and Canada, most, same countries, I guess, they have what's called an all-payer payment system. So, which is really important. So if a doctor who does a physical exam, all doctors that do that physical exam are paid the same rate. And we'll get into the incredible complexity of our system a little bit later. But so that, an all-payer payment system will be explored. And the superintendent has found some experts that have knowledge about what other countries are doing, so that we can learn from it. It's not that we're going to say, oh, we'll do the German system or the French system, but as we learn how they work how their system works, we hopefully will come up with something, and I think we will, that's smothered in green and red chili, that really is appropriate for us. And so, but we need that information. We need to know, and I bet a lot of your listeners don't know, all the payment gimmicks, essentially the payment systems that we're using in the United States, and how frustrating it is for providers. And it's one of the reasons why many of them are retiring, because of this incredibly complicated system. The fourth research topic is extraordinarily important here and now. We know that our hospitals have been in trouble, particularly our rural hospitals, and financial trouble. And the pandemic has just aggravated that. And there is the European countries and Japan and Canada all use something called global budgets. Imagine going to a hospital and not getting a bill of thousands of pages of, $50 pieces for Kleenex. So they're given budgets, just the way our judicial system gets a budget, what agencies get budgets, it's called global budgeting. And it's one of the reasons, the all-payer payment system and the global budget system are reasons why they spend far less than the United States. And what's exciting about global budgets is that Maryland has experimented with it. And CMS, the Center for Medicare and Medicaid Services, has lots of money for a state that wants to experiment with a global budget system. And Maryland's been doing it for 4 or 5 years, and there's no question that they are not only reducing costs, but they're able to invest that in services that are really critical to patients that are not money makers, but are actually helping people not go back into the hospitals, like making sure when they leave the hospital, there is a care system for them through family or whatever, and that they're going to get the kind of care, post-operative care that they need, so they don't go back into the hospital. That's just one example. Pennsylvania has just started its system. And so the fourth research is focusing on educating, particularly hospitals, rural hospitals, about this system, and getting them to think about, how it could work here. And the superintendent also is hiring some experts who are very familiar with how it works in Europe and elsewhere. So let's learn how they do it. And again, what we'll do, hopefully, is smothered in green and red chili, what really works for us. So those are.
How are you going to do that, Mary? You take all this, the way I understand the design process is you first started by identifying how the system works and where the problems are with the existing system. And then you went and you looked in Europe and other countries like Japan and Canada to see how they do it. And effectively, you're compiling a inventory of best practices of how, whether it's setting payments or global budgeting for hospitals, you're going to have an inventory of this is how it's done, and this is how it works. And these are some of the shortcomings of how that system works in Japan or Germany or wherever. But this is some of the benefits. And then you're going to bring it back to New Mexicans, both consumers and patients and doctors and provider organizations, and they're going to take a look at it and customize and take it to the next level and adapt that information and those processes and approaches to New Mexico and our unique challenges and assets. Is that right?
Well, I think Representative Armstrong describes this first year research as, quote, academic almost. Let's find out, what's out there, what we're doing that's good, what's good doing that's problematic, what are these other countries doing that spend far less than the United States. And then we proceed in the second year of design to figure out, what are we going to do with all this information? How are we going to proceed with clearly the biggest costs of our healthcare system is healthcare. So how are we going to providing healthcare? So the payment systems for health professionals and what's going on with hospitals is really key. It's a really key. But there are many other pieces to this research that's going to have to happen down the pike. Mm-hmm. And so we in New Mexico are going to have to figure this out. So the process in which this research is selected and the results presented has to be something very public, very transparent, and we are going to have to develop a process in which all of us decide what the next steps are. The Health Security Campaign is going to do some Zoominars, and our first one is coming up this Wednesday. And thanks for publicizing it in your blog, Paul. And where Representative Armstrong and Senator Ortiz-Pino are kicking off our Zoominars. And they are going to be the focus of attention. And the superintendent has agreed to also do a second Zoominar. And then we want to educate all of us, because my experience is that most people have never heard of an all-payer payment system and or global budgets. And so let's
got your work cut out for you, Mary, because I had 20 years as a health policy researcher and helped design the healthcare system in San Mateo County, California, and a total, what they call total healthcare there. And I read some of the articles you sent me about how this works in other countries and stuff. And I was scratching my head going, oh my God, this is complicated.
It is. And we want to do it slowly and carefully. So all of us feel as comfortable as possible that when the health security plan has been designed, we understand why it's designed in this way. We've had input into that. And we feel comfortable that it's workable. It's going to have problems. Every system has problems. And so one of the pieces that has to be worked into this design process is, how does this commission, that's going to be in charge of the plan, address problems? How quickly can they address them? Where do they get the information about the problems? So there's a lot of detail, and we want to educate all of you about what the choices are and what you think would work, because every one of you has experience with our healthcare system, and you know what you don't like. And so
raising my hand, folks.
Yeah, we want to think about how we can do this. And what's exciting is that this is such a great cheap investment. $575,000, even $1 million next year is really cheap compared to the billions of dollars in savings that every single consultant has said would happen if we did this. I would like to focus a little bit on that. A lot of us focus on the insurance industry, the big bad guys, and it is why we need systemic reform, and not. It's very important for us to look at insuring people right here and now, and not let the ship sink. in a desert. That's a bad image, but it's understanding the complexity of our system, which is in fact the most complex system in the world, and the layers of administration. I really urge people who want to read Elizabeth Rosenthal. She's a physician's book called An American Sickness: How Healthcare Became Big Business and How You Can Take It Back. She focuses on how we individually can take it back. She doesn't talk about the systemic solutions. But what she describes in that book are the layers, all the layers that make our healthcare system so much more expensive than in France or Germany, and the quality outcomes are not good. And I know we think about the insurance industry, they have advertising, claims processing, denying claims, all of that. But, for example, when I mentioned in an all-payer payment system, we have multiple rates for the same service within one office. A physician's office is negotiating not just with Blue Cross Blue Shield, but all the plans that Blue Cross Blue Shield has, all the plans that Presbyterian has, and any other insurance companies. So there are multiple rates. So then they need help in the negotiation process. They also need, so once you have that, you've got a charge system. You have a complex coding system, because the insurance industry or the government isn't going to just accept, here's your charge. They've got a system of coding, which is the most complicated in the world and very costly. And then there's a collection system. I sent you an article, Paul, on physicians as billers. When you go to your doctor's office, if you have insurance, you'd be required to pay a copay, but you don't know the other costs. Neither does your physician know what actually, if you have a deductible, have you met your deductible? If you haven't, what is the insurance actually going to pay? Do you have something called co-insurance? And so we find that we're finding more and more healthcare providers are hiring bill collectors, and hospitals as well. And so it is, there are so many layers. And then of course we've got the labs, the emergency care services that are totally out of control, pharmaceutical drugs.
Mary, I need to interrupt just for 1 second. We have like a minute and a half for the radio show. We'll continue the conversation for the podcast. But if you want to wrap up a little bit, give us your best 1.5 minutes on what people can do and what's coming next in this process. And then we'll dive into more details on the podcast.
Okay, $575,000 is for this fiscal year. It ends June 30th. We obviously, this upcoming session, want to continue this process. You better believe the insurance industry doesn't want any more money spent on this design process. So we need all of your help to contact your legislators, to let them know that you want this design process to continue, and that you want something in the budget to continue, an appropriation to continue this design process.
But you're not going to have a bill.
No bill. No, remember, the bill will happen after the design process is completed.
Okay.
So
you're looking for a line item in the superintendent's budget.
That or a special line item in the budget. And we may need I don't know if we need a bill to authorize the payment itself. We're going to be having discussions with various legislators about the best way to proceed. I would love just to see just something in the budget, period. But maybe a memorial is needed, maybe a bill is needed. And so we'll let you know. But what we want is this process to continue. And you as listeners need to let your legislators know. And since many of you are from Santa Fe, let Senator Worth and Speaker Egoff know that you really feel that this is important. Leadership making this happen is critical.
Okay. Well, thank you, Mary. This has been most informative. We're going to take a deeper dive into some of the issues in the podcast to come. But thank you very much for listening to KSFR today. And thank you for joining us, Mary. And that's all we have time for on the radio show, though.
Thank
So
you for having me. This is so important.
stay active and that's the only way we fix this mess. And boy, it's a mess.
It is.
Thanks a lot. Bye-bye.
There we go.
Yeah. And now we're back for the podcast. So let's get to it. I wanted to ask you, Mary, one of the things we were starting to talk about was the doctors having to be bill payers, bill collectors, and negotiate. They have to also negotiate what they're going to get paid, probably annually or every couple of years. And that's a very big cost item, as is the coding and so forth. But you need to achieve it. I'm guessing that part of the process of the plan and design is to achieve more uniform payment levels. Because as I shared with you, and this is related to pharmaceutical, but I had this stroke, and then I was told I needed to take Eliquis perhaps for the rest of my life. And when I asked what it would cost, I was told $492 a month. And I almost had another stroke. But then we went to La Familia, our health clinic, and asked them for how much would a month cost, and it was $60. Well, that's a big difference. And every time I get a Medicare bill, it shows what was charged for what happened in the hospital and what Medicare is paying, which is always less, and what I'm liable for, which is a lot less. And so I'm taking it that this process would result in a plan that was much simpler. Doctors weren't billing me, and they weren't having to go through these processes, and all of these costs would be basically the same.
What's very exciting, because I've had so many wonderful conversations as our board members and volunteers with healthcare professionals. And, I've asked quite a few people. I said, what do you think of the alternative is to our system? And most of them don't know. They know what they don't like in our system. And so this is an opportunity for all of us to learn about how we would pay, what we do in the United States, what the systems are to pay healthcare providers, and what other countries use, and how we can simplify it. We'll have, one plan for most New Mexicans, which makes things a lot easier. So you're not negotiating with 50 different, policies.
And you're not getting these thick ass books each week about this time of year on how Cigna or whatever plan can save you so much with glossy photos and all kinds of charts and rates, monthly rates and co-pays and deductibles, and you have to try you have to try and do the math on like what's going to work best for you.
I think that's true. There will be supplemental insurance for, if an employer wants to offer it, or anybody wants to purchase supplemental insurance, and there's a market for that, just the way there was with the original Medicare. And so, but will simplify all of our lives enormously, and we're losing healthcare providers, and it's frightening, how frustrating it is, and that for them, if you ask them, as of course, I always curious to know, how they operate, whether they're an acupuncturist or physical therapist, how can we simplify this? And fortunately, we don't have to start from scratch. We can learn from other countries who do it much better. I urge your listeners to go to our website, the Health Security website, www.nmhealthsecurity.org. We have a video that it's the New York Times survey of 8 young people from different countries and their reactions to how we provide healthcare in the United States. And they are shocked. I mean, one said, oh my God, this hospital bill charges this woman who just had a baby for holding her baby. And another one, he said that, he was asked, he had a heart surgery and he was asked, about his hospital bill. What? He said, oh, I got a bill for parking my car. I mean, it's just really, really shocking. When you read, I mean, I was so depressed when I was reading Elizabeth Rosenthal, and here I am, I understand a lot of the administrative complexity. She put in layer after layer after layer. And Uwe Reinhardt, a well-respected health economist who unfortunately died several years ago, he was a co-author of an article, "It's the price, stupid," he said. We're so used to, what does healthcare cost? Well, that's not the question. It's the price of what you pay, not the real cost. And in Europe, Japan, and Canada, they're looking at the real cost, not at, quote, the price. And the prices go up and up and up, and there's no controls over them. And of course, what's happened in the United States is that in New Mexico, when you think about it, more and more people are covered by Medicaid. And what does Medicaid do? It's a public program, taxpayer-based program. Then you've got the health insurance exchange, where people are buying insurance through the exchange, and they get subsidies. Where does that money come from? The federal government. So the federal government, we as taxpayers, are essentially giving money to private insurers to insure people whom they wouldn't insure. And that's true of the history of Medicare. And moreover, I think there are articles now coming out, is that even the insurers can't control the rising hospital healthcare costs. They're not even cutting good deals. New York Times recently had an article that was quite shocking, about their failure to be able to cut good deals for their people they insure. And this all the conglomerates, and essentially a hospital is a monopoly, right, in many ways. And so we've got a very sick system, which is why I think Elizabeth Rosenthal uses the title An American Sickness. We really fail when it comes to providing healthcare. And I also sent you an article, Paul, which I just learned about, there was another one too. Let's take a look at the very wealthy in the United States, the 5%.
I was just going to ask you about that.
Yeah, 5%, and even the 1%. And let's compare their health outcomes to those of the average French person, the average, the overall system, right? Because that includes poor as well. And the results were shocking in this reputable study in terms of cancer and deaths due to having babies, for maternal birth deaths.
And infant mortality
Infant
too.
mortality, colon cancer. It's just, the Commonwealth Fund always collects great data from the World Health Organization and the Organization of Economic Cooperation and Development. And they have these charts that are comparing charts from different countries. And it is shocking, to see, but those are general. They're looking at the total American population and the total European. So this study said, okay, do the wealthy in New Mexico or in the United States do better or equivalent to the high standards of these other countries? And they don't. which is, something so wrong with our system.
So what I found really interesting about that article was that one of the conclusions they drew was that it wasn't that, you know, outcomes, better outcomes were tied to necessarily accessing supremely skilled practitioners and things like that. It was about being in a system that's well coordinated and provides good preventive care as well. And just like, for example, in my example of having a stroke, there would be good coordination of my aftercare, which didn't happen. We were just told to sign up at Christus St. Vincent for outpatient therapy. And when we called them, the first appointment was 8 weeks away, whereas our neurologist had told us the first month of therapy is of critical importance. And so we weren't going to have anything. And the system didn't tell us, well, there's this organization, Permacare, I think it's called, Amber Care, that will come to your home and offer rehab services. We only found out about it because someone from KSFR, one of the members of the board, Peter Smith, knew of them, and he contacted Roxanne and said, you guys should check this out, because if you're having a hard time getting into therapy here. And so we did. And so we had it the next day. We had someone come into the house, and they were coming 3 days a week. But the system didn't know this. The system didn't tell us about that. And, when you're trying to schedule 20 appointments a month, which is what I have right now, different appointments at different times, some in Albuquerque, some here, that's really hard to coordinate. If it weren't for Roxanne, a lot of this stuff wouldn't be happening, because there's no way I'd keep track of it. After you have a stroke, it's hard to keep track of things.
You need an advocate, yeah.
And so, I'm assuming that in a plan designed by New Mexicans based on best practices, that would incorporate care coordination and navigation services, so that, because you just can't rely. I know one of the things I studied when I worked with San Mateo County was that there are this band of users who, for one reason or another, often mental health issues, but not only, who have a very hard time of managing their post-intervention treatment plans, whether that be with diabetes and so forth. And that if they don't, they come back to the hospital with very expensive care costs. But if you provide care support and reminder support, and sometimes it's just peers contacting you and saying, have you taken your medication this morning? Have you tested your blood levels and so forth? And if there's those reminders, then those people don't wind up back in the hospital, and that's good for costs, and it's good for those people.
That's what's exciting about Maryland's global budget experiment, because instead of investing in the money makers, provisions so the hospitals can survive, the guaranteed revenue stream allowed them to invest in, post-operative care, at-home care. And what was interesting in it's 4 or 5 years is the readmission rate was less. Just exactly what you're talking about.
Right. And so part of what, when I was working in San Mateo County, part of what we did was, and it was great. When you're a consultant, you can't do a better thing than to pick the best county health system in the state to start with as your client. And so I did, and worked with them for 10 years. And they were remarkable. They integrated their health care and their behavioral care and their clinical care, so that people who were in getting diabetes for hypertension were getting support and care management, so that they just didn't return to the hospital.
Yeah, and care management has always been important in the Health Security Act. And clearly, I think people need to, if you're familiar with the Health Security Act, think of it as a recipe that has a lot of good ingredients. And maybe there's some new ingredients that we want to add to it in this process. And maybe there's some ingredients we want to adjust. And that the design process will allow us to look at our real circumstances in New Mexico. And there's rural and urban, and there's health disparities. how do we address all that? How do we address the concerns of healthcare professionals so that we actually end up attracting healthcare professionals to come to our state because they can practice medicine in our beautiful state. And all in the cost studies indicate, because our state spends a lot of money, our state budget spends a lot of money on healthcare, not all just on Medicaid, but also on retirees and on employees and on teachers. And, so that's a big chunk of our state budget. And if that can be reduced, the rate of increase is slowed, that frees up more money. Moreover, our premiums go to private companies out of, some of whom are out of state, and they're making money off our premiums. So why shouldn't our premiums go into our own health plan? And we're talking billions of dollars. And if it's invested right, even at 1%, it's going to generate an enormous amount of revenue, so we can build health infrastructure. We can engage in programs that are innovative, that ensure that our rural New Mexicans don't have to travel miles and leave their work to get chemotherapy. There's roving chemotherapy treatments, for instance. And there's lots of things I think we can do to really come up with something that is really appropriate for a state. I had a meeting with Representative Mo Maestas, and he got so excited about this. First of all, he said, oh, wow, there's a really good, solid plan for the design, which is important. And then he sees this as economic development. Healthcare, of course, he said, why can't New Mexico be a healthcare center, given this? And and of course, I was stressing that while there are states that have bills not quite like the Health Security Act, but there's single payer or some kind of bill for universal coverage. Oregon, Washington, California, New York. No one has rolled up their sleeves to say, how do we really do this in our state?
And wouldn't it be nice for New Mexico to be first in something good for
we
once?
have that opportunity, and that's why I need that. Our campaign needs the help of your listeners to make sure that this process is funded. We continue to fund this design process for this coming year, and we know the insurance industry is going to want to try and sabotage that.
Yeah. Well, isn't New Mexico potentially something like, I think it was Saskatchewan? Was it Saskatchewan? That was the first in Canada to do a single payer health plan. And,
yes.
And it was so effective that 2 years later, the whole country decided that they were going to implement, I don't know if it was 2 years, but a few years afterwards.
Yeah, the Saskatchewan was the poorest province in Canada. And then I recently discovered a book on the Canadian system, and discovered that, Saskatchewan just didn't say, hey, whoop, here it is, everybody gets healthcare. They set up a commission to do design. And it took them quite a few years to figure out how it would work. And it makes sense. It's like when talking to many supporters, the light bulbs go off. Well, of course, the Health Security Act would pass, but that doesn't mean that we can go immediately to the doctor of our choice and they're going to be paid. There's a lot of steps that has to go. And so it was quite a few years for them with their commission.
So this is a curveball for you, Mary, but you just said the light bulb goes on. And as we've been talking, I've been thinking about how this system is, and the plan and design process that is needed to develop it is very similar to what some allies of ours are going to be proposing in the legislature around power and energy. I mean, right now we've got Avangrid and so forth wanting to take on the merge with P&M and become our utility leader. And one of the things we're advocating for is public power, where the state takes responsibility for it, invests their resources in a plan that tells them exactly how much money they could make by investing some of their taking some of what they have in reserves, the tens of billions of dollars they have in reserves, and using that money to leverage low income loans, low rate loans, so that they can build the infrastructure necessary to really develop our solar and our wind and export it to other states and Mexico, which is exactly what Avangrid wants to do. But instead of them making the profit, the state would make the profit and diversify our economy.
Mhm.
And the same goes with public banking. It's a similar thing. It's like, why are we giving so much of our resources to out-of-state corporate entities that have virtually no interest in our health, our power, or our economy? They just want to make a profit on us.
Mhm.
So,
Yeah, we've got, there are a lot of issues, and certainly climate change is a major one, dependence on fossil fuel, how much of our state budget has been dependent on a volatile, really what is a volatile oil and gas uh, system. And I know I hear legislators say we can't be dependent on it, but even that transition away from fossil fuels is going to take time, because there are communities that are dependent upon that drilling. And I was glad that, I think it was Senator Stewart and Representative Stansbury and others in the House put together a transition team, bill
right.
to explore that and to look at impact on community. And I think it's important.
Yeah, there can't be a sacrifice zone. You
Mhm.
know, New Mexico's had enough sacrifice zones. So, well, this has been a most interesting conversation, Mary. I'd like to close it by giving you an opportunity to sum up, and also just to tell people where they can get more information. Retake, by the way, will be sending out information about what steps are coming next and so forth, and how people can get involved. But you can get that directly from Health Security for New Mexicans campaign. How can they do that, Mary?
Well, they can sign up in it's our website, www.nmhealthsecurity.org, and you can sign up to be on our email list, where we will give you information. And as I mentioned, we are going to run a series of Zoominars that will be very educational about key issues that most people are not knowledgeable about, and we want to inform people as much as possible about, for instance, provider payment systems. And we're envisioning maybe two Zoominars on that. One is to have a group of health professionals tell you how they're paid, what the system is like, what frustrates them. And then the second one would talk about what are the solutions being proposed in the United States, and how does it work, an all payer payment system elsewhere. Global budgets would be another Zoominar, but we envision doing this. Plus, if any of your listeners belong to organizations, groups that want presentations, we are always willing to do that. No matter where you are in New Mexico, thanks to Zoom, it's very easy to meet with people around the state. And
I can't underscore enough how important it is that people like Roxanne and I and our listeners really get, I mean, when we were trying to pass the health security plan and design in 2021, we wanted to stay as much out of the weeds as possible and focus on the concept and the potential savings for the state. But now we have to understand the weeds. And the insurance industry does understand the weeds, and they understand that it's not going to go well for them if this plan passes and becomes law. And so they're going to be spending big bucks on commercials and on coffees with legislators and whatnot to try and spread misinformation about just the sky will fall and people will be in the middle of the streets with no health care and nobody to help them. I mean, it's going to require that all of us roll up our sleeves and get conversant and be able to talk the talk and explain to our legislators that how that is misinformation. And you can't do that if you don't understand it yourself. So I'd really encourage our listeners to, stay tuned to Retake and stay tuned to the Health Security New Mexico for New Mexicans.org. And we got to get this done. We got to get this done.
Yeah, we really do, because the system is falling apart. There's just no question.
Yeah.
And and I think that it is really important, just like Canada did this, that a state's got to start
Right.
the process. So we need to get, I mean, if you think about child labor, labor laws, women's suffrage, Wyoming was the first state to allow women to vote. I mean, a lot of good legislation that ultimately was passed by a reluctant Congress came from the states.
Right. Right.
And so there's no reason why, and it's a lot easier and for us to develop something that is homegrown and homespun and that really is reflective of our issues in New Mexico. And yes, there are challenges, but I think there's so many bright people in our state. I am convinced we get the data, we get the possibilities, we'll figure things out. And that's where setting up a process, some kind of a commission or advisory board that is coordinating this is critical to make sure we get information, be sure, they have speakers that will tell us stuff, that allow us to have input. They set up, specialized advisory committees, to say, okay, let's work on this. And I just think that we can do it. I mean, I wouldn't be working so hard all these years if I didn't think that this was possible. And this is a new phase for the health security campaign.
Well, and the plan and design process itself is going to be something that engages so many people from the health profession and they're going to feel like their handprints are all over the final plan.
I hope,
So
absolutely. They have to have a say.
That virtually ensures a strong advocacy group in support of the plan, because it's a plan developed by and for providers and patients so that we benefit, not, corporations.
Right.
Okay, so thank you very much, Mary.
You're very welcome. Thank you for this opportunity. And I so hope your listeners feel like they understand a little bit better about this process and how important it is for them to communicate with their legislators about it.
Okay, thank you very much, Mary. Take care.
You too.